My name is Pam Block. Welcome to our final presentation of our Western University, Brazil, Canada, Universidade Federal de Santa Catarina speaker series on disability research topics. This is the fourth presentation that we have offered this year. Our presentations are available in with captions in Portuguese and in English. And today we have a sign language interpreter. Right now the interpreter is highlighted. If that does not work for you, please let me know in the chat, but right now she's highlighted so that she will be visible in the recording. Today's presenters are Erica Katzman, who is an assistant professor of disability studies at King's College, and Marco Gavero, who is a doctoral student in sociology at the Universidade Federal de São Carlos in São Paulo. And I am going to now turn the mic, the virtual mic, to Erica to begin her presentation. There will be speaking about, I don't actually have the title in front of me, but I believe it is about how disability is produced in rehabilitation contexts.
Thanks, Pam. Just getting my slides up here. Can you see them okay?
I can't see you, but I will work on that.
I think if I add a spotlight, can you see
There
me
we
there?
go. Okay.
Perfect. So just before I speak to my slides, I've got a link here at the top of the screen. That's tinyurl.com/allyship-and-health. If anyone would like the access to the PowerPoint slides, you'll be able to find them there. I thank you, Pam, for the introduction. I will mention as well that my background, or sort of how I found my way into disability studies, was through my PhD in rehabilitation science, where I focused on health professional education. And I mentioned that because I'm going to present a couple examples today that focus on the construction of disability in health professional education. I titled today's talk Medicalization, Ableism, and Allyship in the Health Professions, because I think that despite some increasing awareness of socio-political dimensions of disability in health and rehab sciences, our fields remain very deeply entrenched in a medicalized understanding of disability. And I would suggest that healthcare professionals are really well positioned to support disabled clients by serving in more of an allyship role. I think we're often very well intentioned and do want to support disabled clients, but struggle to achieve that because of some of the ways that our practices are very outcome oriented in terms of the kinds of therapies or interventions that we think about. And also that we sort of become this way because of how our education is oriented. And also through systems and structures that things like a discourse of evidence-based practice that really privileges a medical and scientific knowledge about disability. And so I'm just going to flip my side here. I'll start off with a sort of an introduction to this idea of medicalization, which I suspect will be a familiar concept for many, but maybe a less familiar consideration is how we might think about medicalization as related to ableism. And to get there, I want to look at these two particular examples. So one is looking at how the definition or understanding of client-centered practice has evolved in occupational therapy texts, and also how disability is constructed in personal support worker education, looking at a textbook there as well. And from there, hoping to go into a bit of a discussion about what is missing from medicalized health professional education, focusing on the idea of disability as culture and opportunities for healthcare professionals to reimagine our relationship with clients in terms of allyship. So I want to start with just a distinction between medicine and medicalization. So in disability studies, we're often quite critical of this idea of medicalization, and sometimes medicine gets caught up in that. So I think it's helpful to distinguish that people may genuinely want and benefit from medicine or medical therapeutic interventions. Medicalization is a little bit of a different beast, and really refers to the process of defining disability as a problem, and specifically a problem that must be addressed through medical intervention. And so the effects of this are to foreclose or preclude alternative ways of thinking about disability, and also this sort of situating of disabled people as medicalized objects to be intervened upon by knowing or expert healthcare professionals. I'm drawing on Hayes and Hanold's discussion of medicalization here, and they really emphasize the power dynamic that results from this construction of disabled people or clients or patients as medical objects, and in contrast to that, healthcare professionals as in a more subject position as knowers. Just moving my slide to a first example. So one place that we can see this medicalized construction of a client or patient in contrast to the knowing healthcare professional is in our core Canadian occupational therapy textbooks, Enabling Occupation. So I'm drawing here from observations that were actually made by Karen Wally-Hamill, that in 1997, in our first edition of our textbook, the therapist role was described, the therapist role in client-centered practice was recognizing clients' experience and knowledge. That was one part of the definition. And Hamill notes that in our 2002 second edition of the text, the language shifted to center the therapist as the enabler, enabling clients to participate, and just sort of dropping that acknowledgement of the client or the disabled person as knowledgeable or as a knower. And then in our 2007 edition of the book, the therapist role is described as employing enablement skills in a collaborative relationship with clients. So in this more recent definition, the client is not portrayed to take any active role at all. The therapist is centered as the actor on or for the client. And I just included a reference here to a piece that I did with a colleague, Stephanie LeBlanc Olmsted, who works a lot with the idea of epistemic justice, and so has some really neat things to bring to this conversation, thinking about how this factors in as a justice issue, that people's knowing is suppressed in some contexts. So I want to flip to my second example here, looking at how medicalization is turning up in a current study that I'm engaged with that's looking at how disability gets constructed in personal support worker education. So just to give a brief background here, this study, the impetus for this study comes out of my previous research on self-managed or direct funded attendant care services. So where people who need support services, who might be called clients or service users, or in the Ontario program, self-managers, actually pretty consistently prefer to hire people who don't have formal training in a personal support worker education kind of program, and presumably because they haven't been trained to think about disability or disabled people in a particular and especially medicalized way. So this study is a critical discourse analysis of a leading Canadian textbook called Mosby's Canadian Textbook for the Support Worker. And just using critical discourse analysis, thinking about the textbook as an object that mediates a particular cultural understanding or knowledge, and looking to answer these questions that I have here on the screen, that are: how is disability represented? How is disability not represented? What does this teach trainees? How is the personal support worker role constructed? and how is the personal support worker-client relationship represented. My next slide has just an image of the textbook cover that has these 4 arms and hands interlocking with the title of the book in purple and green overlaid. And my title question on this slide is, how is disability represented in this book? And the key finding, and I was kind of surprised by this finding, was that this is really not at all a book about disability. So the book does have sections that teach about different categories of physical and cognitive impairment. It covers things like developmental stages. But whenever it's not speaking about a specific impairment category or client group, the sort of default assumption seems to be this damaged, lacking, aging, declining older adult client. And really throughout the book, there's minimal, if any, recognition of the socio-political nature of disability or disablement. As far as how disability is represented throughout the text, really as this kind of, again, not really as disability or a disabled person, but this client is constructed as a passive, vulnerable receiver of care, not a knowing subject, but really as that medical or object of medical intervention. The support worker, by contrast, is really situated as the knower. So the textbook is teaching about impairment so that the trained professional can apply their expert knowing to care for this medicalized object of impairment. As frontline workers, the support worker is really positioned in this surveillance role. So they're instructed to observe and report back to supervising professionals. The support worker there is a narrative in the book that's teaching empathy. So teaching the support worker to empathize with the client's conditions, but those conditions are pretty consistently represented as unfortunate. And really while that thread is there, the primary narrative is that the support worker is, through the book, being taught to know this ailing body, this ailing mind, so that they can effectively learn to manage it. My next slide here, or slide title, is How is Disability Not Represented? And my subtitle answering that question is Disability as Culture. So I'll come back to this in a moment, but I just want to share a quote. And this is a quote from Stephen Brown, who is a co-founder of the Institute on Disability Culture. So Brown wrote or described disability culture as a set of artifacts, beliefs, expressions created by disabled people ourselves to describe our own life experiences. It is not primarily how we are treated, but what we have created. So this idea of disability as culture might refer to material artifacts, things like technology or art, but really conceiving of disability as culture also opens up an understanding of disability as a different way of being in the world. And so there's knowledge that comes with that, that divergent or diverse way of being. One commonly cited example is a profound understanding of interdependence that comes from innate familiarity with having needs, needs that aren't being met, or a kind of engaging in what ends up being like a countercultural practice of asking for help, or having a heightened awareness of needs and help, and participating in sort of community initiatives to help people navigate access needs. A different example might be a very nuanced understanding of ableism, an experiential understanding of ableism as a systemic oppression, and specifically one that intersects and interlocks with other systems of oppression. To go into that a little bit deeper, I'm going to share an image here with some text. I'm going to start reading actually at the very bottom of the screen to introduce what this is. So reading from the screen, this is a working definition of ableism by Talila T.L. Lewis, updated
I just want to
January.
interrupt just for a second to say that the Portuguese translations of the captions are now available. The link is in the chat for anyone that needs it. na language de português dos Cações está no chat.
So this is a definition, working definition of ableism by Talila T.L. Lewis, updated January 2021, and developed in community with Black, disabled, and other negatively racialized people, especially Dustin Gibson. So the text here, against a purple and blue background, presents the following definition of ableism as a system that places value on people's bodies and minds based on societally constructed ideas of normality, intelligence, excellence, desirability, and productivity. These constructed ideas are deeply rooted in anti-Blackness, eugenics, misogyny, colonialism, imperialism, and capitalism. This form of systemic oppression leads to people and society determining who is valuable and worthy based on a person's language, appearance, religion, and/or their ability to satisfactorily reproduce, excel, and behave. And just set apart as a separate paragraph, the following text: you do not have to be disabled to experience ableism. And I just highlight that part because we'll come back to it a little bit later. So changing the slide here and coming back to this idea of medicalization and as ableism. So with Lewis's definition of ableism in mind, I want to encourage us to think about medicalization as related to ableism in a couple of ways. So in that medicalization constructs disability as essentially a problem of normativity, so of deviance from normal functioning. Through healthcare, through intervention practices, this medicalized processes really prioritize a return to normal. I think in practice, we often supposedly or ideally talk about this return to normal as client-centered, or perhaps what we mean by that is client-defined or defined with input from clients. But realistically, and I'm going back to the way that Hayes and Hanold discuss and theorize the healthcare professional role under medicalization, realistically, rehabilitation practice is often oriented to achieving or restoring productive neoliberal citizens. So in their definition, Hayes and Hanold describe health professionals as agents of normalizing power. So bound to health and medical systems that while they may aim to empower people, are primarily concerned at a systemic level with maintaining the status quo. Thinking through the definition of ableism that we get from T.L. Lewis as ableism intertwining with other systems of oppression, I just want to draw another connection here to some recent work by occupational therapist Marie-Hélène Grenier, who points out that normal in therapeutic contexts is often presuming dominant, white, or Western, and I might add in here, enabled cultural values. So changing the slide here to move on to talk about implications of this discussion for health professional practice. And always the hopeful question of what can we do? So given that, person fixing is quite literally the business that rehab professionals are in. As medicalized fields that are bound up in these discourses of evidence-based practice and outcome-oriented funding structures, I think it's challenging actually for us to integrate these kinds of disability studies critiques. Challenging, but not impossible. So one way that I'll suggest we can adopt a more allied approach to clinical practice is through reflexive awareness of the power dynamics that are inherent in our relationships with clients, understanding that even if I think we are having conversations at the educational level amongst ourselves, but at the same time as we're having those conversations about awareness of power dynamics, we're also situated among these swirling dominant cultural narratives that reinforce healthcare providers as experts and systems that situate healthcare providers as gatekeepers. So so long as clients need to pass through healthcare providers to gain access to supports and services, they're really going to be compromised in their freedom to self-advocate, lest they upset or lose the support of a professional ally. Genuine client-centeredness, then, I think, requires that healthcare providers not only seek to empower clients to understand their options and to make informed choices, but also to recognize that disabled people are experts on disability, and not, you know, every person on every disability, but really on their own bodies, on their own contexts. And so creating genuine space to bring that knowledge, expertise into the practice context. Moving to a next slide, another point for implications, thinking about what demedicalized care might look like. That might mean recognition that interactions with healthcare professionals are but one stop on the lifelong journey of interacting with these medical systems for many people with chronic conditions. And so the potential is there for endowing people with tools for self-advocacy or for system navigation, alongside, and in some cases, maybe even in place of, those outcome-oriented therapeutic interventions. To go along with that, I just want to share another quote that I've always really appreciated from Karen Wally-Hamill, that a focus on changing cultural attitudes towards disabled people might have a greater impact on their lives than teaching them exercise regimens. And lastly, just returning to the implications for a final point here, I want to introduce a term that I can't say I've seen much of, if at all, this idea of anti-ableist care or practice. So I hope that maybe this idea can start to gain some traction, this notion of anti-ableist care as a genuine support of what is best for individuals, even if it's out of step with societal norms or sort of typical therapeutic goals. And recognizing that entering into this kind of approach, an anti-ableist approach, will likely require clinicians to confront their own internalized ableism. So the assumptions that we hold about what is normal or right and good. And then also committing to work on the ableism that we see in those structures that invalidate disabled people as legitimate knowers. And that's all. I'm just going to switch to a references slide in case you want to see where some of these have come from. And then I don't know, Pam, if we'll go to sort of questions, or if we'll go to Marco now and then have some discussion at the end.
We'll go to Marco now and we'll have some discussion at the end.
Great. I'll stop sharing my screen.
You ready, Marco?
Yeah, I'm ready. I'm just setting up my slides first. You see, now you see it. Just open my text.
Yes, we can see your slides.
Okay. I'm gonna set up this first slide, and when I'm introducing myself, and next I'm moved to the other slide. That's only a slide that I'll show you to you, and while I am reading my text. Okay. So first of all, I would like to thank CAPS for funding my research in the postgraduate program in sociology at UFSCar, which I also thank. I also thank the Department of Anthropology at Western University and the Center for Disability Studies at UFISC, for the invitation to participate with you in a series of discussions on disability between Brazil and Canada. Specifically, I thank Professor Pamela Block for the opportunity to build connections between North American and South American predictions of disability studies. And obviously, they are studies that even propose critics of dichotomies between what is North and what is South, between what is above and what is below, what is more to the left, what is more to the right, out of the historical context, the historicized prediction of these dichotomies are ways of seeing the political spectrums of our times and of delineating our current geopolitical and economic disputes, but they are also representations that influence, produce, and are conditioned by the embodied collective lives and experiences. I am also grateful for the possibility of being in contact with Professor Erica Katzman. Professor Katzman is a reference in many of the questions I went into during my doctoral research, especially in the dimension of the prediction of disability in the areas of public health and rehabilitation. So this is my thanks. My presentation today will call notes on the prediction of functioning in rehabilitation practices. And today I will comment with you on my recent attempt to think what might come under the term disability/impairment prediction. From an ethnography developed in a clinical rehabilitation laboratory for young people and children with disabilities in the interior of Brazil, I observed and tried to describe how the techno-scientific prediction of functionalities or of functioning and human capacities took place in practice. With clinical rehabilitation laboratory, I want to offer you an image, a metaphor of a place where scientific research and therapeutic public services are intertwined. Pedagogical practices for training health professionals are also produced there. But this dimension, unfortunately, is beyond my scope in this talk. However, my focus was on where ability capacity terms were elaborated in the clinical practices done by physical and occupational therapists in this clinical laboratory, and how they might correlate to the current notion of functioning promoted, especially in the last 20 years by World Health Organization. According to the specialized literature, human functioning is an umbrella concept in which the bodily, cognitive, and social abilities of individuals are agglutinated. In contrast to the notion of functioning is the umbrella notion of disability. Disability in this case is the negative counterpoint of what be the agglutinated components of functioning. Therefore, within these domains of functioning and disability, we would have respectively functions and dysfunctions on the side of the body, functional abilities and limitations that are tasks and activities, and participation and restriction in social environments or community environments. A first dimension of that, from my ethnography interaction with health professionals and with users that in the United States we call clients or patients of this clinical rehabilitation laboratory, it was possible to partially observe how the dimensions of functioning and disability unfold, or how these dimensions of functioning and disability co-produce each other. An ethnographical example or an ethnographical glimpse of this process of this is how the notion of functioning is translated in the daily life of the clinical laboratory. In a general sense, the idea, this idea, the function idea suggests things the individual can do or things the individual could do in a controlled environment or in a real domains. These two semantics are customarily interchangeable. What matters to us here today is the notion of doing, because the notion of functioning in clinical practice is codified as an aggregation of abilities, skills, performances, and capacities that are necessary for the individual to move and participate in social space. In this sense, functions and dysfunctions or impairments, limitations and abilities, performances, capacities, and restrictions may themselves be subsumed into a thing that I am calling grammar of functioning. It is here that I would like to situate a possible prediction of disability impairment within the current therapeutic and scientific searches to promote functioning in individuals. So I am seeing the rehabilitative practices as a way, because that is what the professionals that I relate in my ethnography tell me that the goal is to produce individuals in that specific way of functioning. In the attempt to guide treatments based on what individuals can actually do in their real domains, in their real environments, their performances, that also merge the considerations of what individuals cannot do with their bodies and minds, that we call impairments, and what they cannot do socially, which would result in disability. This is how we see an expansion of rehabilitative practices using, even clinically, notions such as restriction of social or community participation, rehabilitation based on participation, rehabilitation for social participation. At the same time, these practices have shifted to a very notion of rehabilitation as something aimed at body and behavioral corrections to something corresponding to practices that promote, induce, produce more functional bodies or more capable individuals. In this sense, it also displaces the very dichotomy of impairment, disability, as foundations of corrective practices. To biopsychosocial components that don't necessarily disappear, but that need to be managed and minimized, as Professor Katzman explained to us. Now I'm gonna move to my other slide. And continuing my presentation. In Portuguese, we translate ability as habilidade and capacity as capacidade. However, in the health area that is concerned with medical and social aspects of disability, especially in the rehabilitation sciences grammars, it is quite common to translate the terms ability, capacity by the only term capacidade. In a didactic sense, we could think that abilities would be correlated to dimensions projected onto individuals, and capacities to dimensions projected onto the social world. Something similar happens with the official Portuguese translations in the health areas of the term disability. Here in Brazil, the term disability has been officially translated as incapacidade, exactly to differentiate the translation of the term impairment as deficiência. Thus, impairment is of the physical cognitive dimensions, and disability tends to be linked to the behavioral and social dimensions. However, in other dimensions, such as the bureaucratic and political, the term disability is also translated as deficiência, just like the term impairment. In other words, culturally in Brazil, there is a tendency to refer to impairment and disability from the term deficiência. This has generated localized bureaucratic and political tensions as ways of measuring and defining disability at the governmental level have come to be guided by the grammars or spectrums of functioning. So these discussions between what happens in the clinical practice of the rehabilitation in Brazil or in some locals of clinical practices of rehabilitation in Brazil are now become intertwined with the classifications and the things that World Health Organization has worked in the domain of functioning, and functioning as a way of classify and to set up services, health services, social services to disabled people, to persons with disability in Brazil. But uh, at the same, in the same side of the clinical rehabilitation practices, or in the side of the clinical sciences, or the rehabilitation that are become evidence-based, this this grammar of functioning is very much confusing for the proper agents of the health service, for the professionals that work in those space. And for example, the health professionals like physiotherapists or occupational therapists uh, uh, during much time deal with this grammar of functioning. So what I'm trying to show to you that how those translations, be the language translations, how disability is translated in Brazil, how impairment is translated in Brazil, or another set of translations that is what we can translate the universal categories that are being prepared in the political level or the classifications level can be uh, absorbed by the professionals of health or the social workers that are uh, indicated to organize the social production of disability in the sense. So to finalize my participation, I will present some propositions to close the reasoning and so that we can advance the discussions at later moments. First, the disability issue in Brazil currently is a broad space of social, technical, and techno-political disputes. This includes disability as a category, a concept, and a form of social, political, and bureaucratic administrative distinction and labeling. Two, it is these areas of health and of the social that hold more political and administrative legitimacies to propose and modify classificatory parameters on disability at clinical, laboratory, and bureaucratic levels. Three, currently in Brazil, the grammar functioning as an orientation of the current global health policies proposed by World Health Organization are being designed by still parallel offices. These instances are the differential ways that the functioning disability dichotomy is operationalized in the clinical and scientific dimensions, and on the other side, in the bureaucratic and administrative dimensions. And fourth, the social sciences are still an area that, despite their great influence for less pathologizing models of human health, or demedicalized models of human health, appear in an incidental or instrumental way in a debate about rehabilitative practices and their clinical protocols that have aimed to broaden the social participation of certain individuals. So, what I'm trying to show you with this table that are in my presentation is how we here in Brazil, we are dealing with this grammar of functioning, looking for the ways disabled people can do things or could do things in a specifically environment, but the culturally specifically ideas that are rooted in the Brazilian society that disability is like pathology or like a disease or that are direct links between impairment, disability, and social disadvantage are being meshed right now in the clinical practices, in the scientific practices, and in the bureaucratic level of the Brazilian government. Now we are preparing. It's a thing that it was approved last year, and that is a Brazilian functional index that will propose a unique evaluation for labeling who are disabled or not disabled in Brazil. And this approval of this index are is making a lot of professionals of health areas uh, to collide in their senses of what disability is and what disability is not. So, in my view, we are at the moment of this transition of those models of consequences of disease to these models that are seeing the promotion of the human functioning. So that was my my task in my last research, in my doctoral research, trying to see how this grammar of functioning could be translated in clinical practices for rehabilitation for disabled people. So I am finishing here, and thank you all.
Okay, do we have any questions for Marco or Erica? You may either put in the chat or we can, let's see, we have, will the caption transcript will be made available to the participants after this session? We can on request. What we generally do is add it to the YouTube, add both the Portuguese and the English we edit or incorporate the edited versions onto the YouTube, and then it's available when the YouTube is available. But if people want transcripts, we can provide them on request when we receive them ourselves, because the edited version doesn't come to us right away. The Portuguese version, though, you can just grab and copy it. We're going to be doing the same thing. They don't edit the Portuguese version. We do that ourselves. So we do that before we upload into YouTube. Let's see. And the email addresses for that request, Doreen just put into the chat. Do we have other questions? Let me see. Does anyone have any questions for us? You can let me know in the chat, and you can unmute yourself. Here is a question for Erica. Have you looked into or thought of looking into textbooks from other countries, from other OT traditions from other countries?
Thanks. It's a great question, suggestion. That's I would definitely like this. Looking at the textbooks hasn't been a broad area of research that I have been engaged in. The OT textbook, it was Karen Wally Hamill who made the observation about the representation, and I've been focused on personal support worker education, partly because of my research around direct funding and sort of the implication of the preference in direct funding of not hiring trained professionals. And then also because there is a personal support worker education program here in London, Ontario, where I am, that is interested in knowing more about bringing disability studies perspectives into their training. But I think it's it would be an important consideration. How are the rehabilitation concepts thought about or theorized differently in different like cultural spaces or geographic spaces, because I would imagine that there probably are differences. I haven't looked at it, but I think it would be worth looking at.
We have a question for both of our speakers. Let's see. How can, oh, the chat keeps moving before I can read it. Can you reflect on the impacts of COVID-19 on forms of isolation and care for people with disabilities?
I could, yeah, so reflecting on impacts of COVID-19 on forms of isolation and care. I mean, it's been a really rough year. I think like sort of one of the early impacts that we saw were people's, you know, the sort of public response to COVID-19, at least, I mean, I'm speaking about Ontario where I am. The public response sort of looked to the majority of people, right? It looked to use sort of the language that we're talking with, sort of like normative social experience, life experience. So there wasn't a lot of, I mean, from where we are positioned, we might imagine that people who are disabled, who might have compromised immunity or be experiencing higher levels of isolation already, should be prioritized in the public response, but I don't think that that was what we saw. So I think it has been, COVID has been very, very isolating. It's been I mean, just speaking from personal experience with folks who I share community with, have been anxiously awaiting a vaccination because they've been felt very confined to their homes for their safety for the past year, really. And there have been some really interesting politics surrounding prioritization for vaccination based on the types of care that people have access to. So people with nursing care have sort of moved up the list. People with direct funding somehow have been prioritized ahead of people who have other forms of home care services. So there's, it's interesting to sort of think through this and wonder who's making these decisions and how they're aware of these actual sort of cultures and systems, how they work.
Well, I think that here in Brazil we are experiencing the the almost the same thing about this prioritization of disabled people for COVID treatment or COVID vaccination or things that are related with health services or the personal care of disabled people, but we are struggling. But these are things that are um, inside of our uh, political struggling. Not only about the federal government or the the ways the Brazilian federal government have been labeled as genocide or things like that, but uh, our political experience of the COVID are much more diffused on this issue because the responsibility of the health services in Brazil is, of course, from federal government, but it's the responsibility too of state governments. So we are in the middle, the population, disabled people are not, are in the middle of these political issues that are involving the epidemics of COVID-19. And I think that we have to 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 talk more about these political implications of the effects, not only the causes, but the effects of COVID-19 in the disabled lives, but as I think that Professor Katzman said in the um, ableism, because I am I'm very happy to see that that phrase that ableism is are not a thing that uh, feel by disabled people. Ableism is a set of practices that distinguish the people that are able or not able to do something in the political sense too. So these COVID-19 crises are becoming much more unsustainable in the way that we see the pandemic as a technical issue and not a political issue. So I think that we in disability studies, in health studies, have to grasp with the notion that health, public health, universal health, quality of life, it's a political issue as a scientific issue that is also political. So I'm very concerned with these proposals that are trying to make the health, disability, functionality, functioning things that only will be resolved in the technical level. I'm very concerned with it because if we take off the political of the technical, we have only a technocracy, and that is very in the. I think that's the problem that Professor Katzman tried to show us today, that these personal-centered practices um, have to be more political than technical, have to be more culturally seen as a culturally thing, bound up in technical, in scientific, and clinical, but they are social and historical too. These practices are practices that are put in a historical perspective. So I think that we have to, we'll see, we have to look further to know more about how the COVID-19 will represent a point of disablement in the Brazilian population. Unfortunately, we have to wait to see that. But these are those things are very makes me very preoccupied about it.
I have a question for, or there is a question for Erica. Do you see some of the same terms that Marco highlighted in the books that you looked at?
I don't know if I've seen the terms necessarily, but the concept, like the concepts are definitely there. That idea, like it was just shocking to read it's so tacit. Like it's not like the book says, you know, people are broken and deficient, but it's very subtly written into the way that the workers are instructed to, you know, be aware that people might be be aware that someone might fall and be ready to anticipate that. And it just sort of instructs in this way that doesn't tell you to assume anything except for the fault in the person. And yeah, the same way that Marco described sort of like a cultural, like language conveys something about our cultural understanding. And I feel that even if the terms aren't the same, definitely, I feel that the messaging embedded in the language is the same.
So there is a bunch of questions here that are all of a theme from Marco, and I think he may have responded to Maravecci's question already about the implication of the Brazilian index of functionality. Oh no, maybe you haven't. But so about the Brazilian index of functionality, can you talk more about its implication for Brazilian public policies? And can you, to go on to the questions from Valeria and Elisa, can you provide some examples of this in practice? And Elisa is particularly interested in practice with children.
Okay, thank you for all these questions. And about the Brazilian functioning index, um, uh, it's a very long process. It's to the prediction of the last version of our functioning index, and it's a process that are matched up with various agents, government agents, uh, scientists, researchers of health field, of the social sciences, of anthropology, of the social services, and we are at this moment that the index have been approved, have been all the scientific research that are made, but when the discussions of functioning, of labeling, enter in the public space, enter at the social movement space, enter at the bureaucratic levels of um, um, principally in the ways that this index will work to labeling some people as eligible to or not eligible to public services as disabled people. I think that we are seeing some contradictions that are expected when you modify a way of seeing a population. For example, if we see disability as a cause, as a consequence of disease or a consequence of illness, we have a specifically way to see people, to see disabled people. When we installate in the uh, administrative practices that are intertwined with clinical practices of validation, of evaluation, of assessment, of body assessments, of cognitive assessments, the uh, the functioning idea tends to be complex for a model of disability that are much more linear that we are seeing today. So there are some experts, most of them are physicians, that trying to maintain the identification of disability only on the body level. And these are became a political conflict in a moment that here in Brazil we are passing through a big process of austerity of public services, of access in health, in the eligibility for social security based on disability, and the index of functioning are enter in this process in those various political conflicts. And I think that it will generate more conflicts because we are dealing with power relations. The the medical area is seeing that the their mode of legitimizing their power, they are seeing that are under threat for that ways of different ways of classification of disabled people on based on functioning. But I think that on the other hand, the functioning debate in Brazil is very tied to the social modeling of disability, and that is it's a good case. But that functioning model, it's a biopsychosocial model. It's not a social model per se. So in my point of view, it's a good thing to make things more professionals categorization of disability, but the disabled people are gonna experiment the problems of multi specialization, because the grammar of functioning, besides the goal that is the unification of language, unification of grammar, it's a language that is being learned for most professionals in clinical areas, in the social services, in the administrative spaces. So to summarize it, the functioning index will gonna resolve some things, but will create some other problems. So the researchers have to be this in mind. It's not a romantically thing that resolve all our problems on disability services. No, that's a good way to see the complexities of disability, but it's not a magic pill. I think of that. And about the examples of these production of social material practices that are promoting functioning, is that it's that a simple thing that I saw in field, observing some clinical attainments, observing how the occupational therapists making their protocols, how physiotherapists relate to the occupational therapists. It's the very point that I saw the prediction of functionality in the space I've made research, field research, was that the possibility to teach body techniques to children and to young people, or how to do things with their bodies. An example.
A very short example because we're almost out of time.
Okay, no, it's a very short example. A child that need to learn to make transfer for the wheelchair to the ground, to the ground, to the bed, to the bed, to the wheelchair again. Because his mom was very concerned that they are going to the ground, get out of the chair, wheelchair, going to the ground in unsafe ways. So in the occupational therapist, the physiotherapist became aware of this demand, of this family demand, and started to make some exercise, but not only exercise, but trying to show to the child ways that can do some things properly with his body that wouldn't result in things that will hurt him. So, in this clinical lab with children specifically, we see this moment of teaching how to cope with, can see, if you can talk in this way, how to cope with the body that won't be healed, as the classical way we imagine that a person with an acute disease will be healed. No, the child has yellow meningoceles, and he's gonna be cured of his condition. So he have to learn to do things with the body, how to get out of the wheelchair. This is a functionality. This is a function. This is a way to do things with that specifically body.
Thank you. Thank you so much, both of you. We are slightly beyond our time. This was really wonderful. Oh my goodness. Sorry about that. I want to say our final event of the year for this exchange, this dynamic exchange on disability between students and scholars in Brazil and in Canada is going to be on the 26th of April. We have booked Petra Kuppers to facilitate a dialogue or a connection. This is a very stressful time for many people. So a healing dialogue, we'll be discussing decolonizing disability, but also trauma, the current traumas that people are experiencing, and healing. So if you haven't had the chance to interact real time, virtually, but in real time with Petra, you know, we're going to give priority to the Brazilian and Canadian students, but we can hopefully open it up beyond the two universities to include other people who are interested, and especially people who have committed their time and spoken with and for us. So again, thank you so much, everyone. And we will be back in September we already have an incredible slate of paired presentations for next year and probably beyond next year. We have so many wonderful programs yet to come, presentations yet to come in the speaker series. So thank you, everyone. And I'm going to say goodbye to our audience. But if speakers want to and captioners and translators, you are off duty. But if some people want to hang around and chat informally, we can do that. I have to leave in about 5 minutes to pick up my son, but we definitely, you know, I can keep it open since you guys are co-hosts, so we can keep it open if you like. But if you have to leave, we respect that as well.
That's great. Thanks, Pam, so much for the invitation to take part. This was really great.